Hi everyone, we are starting another great presentation that is called Postoperative fever. And this one is divided in two parts, so this one is part 1 and you can find another one as a part 2. So in this part we will touch many points like objectives, introduction, epidemiology, pathophysiology, and of course classification to understand at which day and how it is called. So our objectives are to identify the common etiologies of postoperative fever, evaluation of patient, treatment and management, and of course describe interprofessional importance of team strategies for improving care and outcomes in patients with postoperative fever or POF. So postoperative fever as a definition is defined as a temperature more than 38 grades of Celsius on 2 consecutive postoperative days or more than 39 grades of Celsius on any postoperative day. So fever as a manifestation of sepsis should be promptly identified and managed appropriately to lower mortality rates in such cases. Underlying conditions, for example, in immunosuppressed or immunocompromised patients, may have a reduced inflammatory response and, of course, a reduced fever or reduced reaction, while at the same time having a very serious or serious infection. Differential diagnosis should include infectious and non-infectious as etiologies, like infectious nosocomial or a surgical site infection, and non-infectious like deep vein thrombosis or DVT or pulmonary embolism, myocardial infarction, drug-related like anesthetic drugs, inhalatory or neuromuscular blockers, transfusion-related, especially to fresh frozen plasma or concentrated erythrocytes, endocrine-related, for example, adrenal insufficiency or steroid storms that increase activity and energy producing. And fever is more likely to be due to infection as the time interval following surgery increases. So if a patient follows surgery, the infection is most common or most likely to be. So postoperative fever is very common and estimates from different surgical procedures reveals that fever occurs early in the postoperative period, anywhere from 20 to 90% of patients, a lot. And the majority of these cases of fever usually occurs on the first or second day after surgery and has been linked to benign cases or benign causes. Postoperative fever is known to occur after all types of surgical procedures, so any intervention, any cut or any incision, irrespective to the type of anesthesia, and can occur after minor surgical procedures, but is rare with minor. You, of course, are familiar with terms like SIRS or SIRS, sepsis, severe sepsis, and septic shock. So SIRS or systemic inflammatory response syndrome have 4 criteria like temperature more than 38 or less than 36, heart rate more than 90 beats per minute, respiratory rate more than 20 respirations per minute, and white blood cell count more than 12 or less than 4, timed by 10 per liter. And 2 of the 4 criteria are needed to identify a patient with SIRS or SIRS, and 2 of the SIRS criteria plus a suspected source of sepsis are required to diagnose sepsis. So if you know these 4 criteria, you add a suspected source, and it is called sepsis. If you have a sepsis, patient with sepsis, so 2 of the SIRS criteria plus suspected source, it's called sepsis, plus organ dysfunction is consistent with severe sepsis. And severe sepsis plus refractory hypotension. Refractory hypotension means that it do not react promptly to fluid resuscitation, or is refractory to fluid resuscitation and need vasopressors, and it is consistent with septic shock. You see signs of organ dysfunction like systolic blood pressure less than 90 millimeters of mercury. It is called hypotension. Mean arterial pressure less than 65 millimeters of mercury. This pressure, usually organ perfusion is okay and going well. And if this mean arterial pressure is lower than 65 or 60, it will have consequences like organ malfunction or injury. Drop in blood pressure greater than 40 millimeters of mercury, especially in patients which are hypertensive. Lactate level more than 2 millimoles per liter is indication of hypoperfusion. Urine output less than 0.5 milligrams per kilogram per hour for 2 consecutive hours. Drop in a Glasgow Coma scale score, or another abbreviated mental test score. So you see a classification, and it is classified, of course, by period or days of fever appearance. For example, immediate fever is called when appears on day 0 to 1, acute fever from day 1 to 7, subacute fever from week 1 to week 4, and delayed fever after more than 4 weeks. Immediate fever, so postoperative period, days like from 0 or immediately after surgery to 1 day. And it could be a malignant hyperthermia, which is a high-grade fever, more than 40 grades of Celsius, that occurs shortly after inhalational anesthetics administration or muscle relaxants. Inhalational anesthetics like halosan, but it could also be sevoflurane or isoflurane or any other inhalatory anesthetic, or succinylcholine. And also may have a family history of death after anesthesia. It's like related to malignant hyperthermia. Laboratory studies reveal metabolic acidosis and hypercalcemia. If not readily recognized, it can cause cardiac arrest. If it is recognized, you should administer as anesthesiologist intravenous dantrolene and 100% oxygen. You should make correction of acidosis, cooling blankets as temperature is very high, and watching for myoglobinuria or detect myoglobinuria. Bacteremia, high-grade fever, more than 40 grades of Celsius, occurring 30 to 40 minutes after the beginning of the procedure. So urinary tract instrumentation, as example, in the presence of infected urine. Management include blood cultures 3 times and starting empiric antibiotics. Of course, after we have blood cultures, we know which antibiotic is sensitive and is good to administer, but till the time we have to administer or start empiric antibiotics. Gas gangrene of the wound, so high-grade fever, more than 40 grades of Celsius, occurring after gastrointestinal surgery due to contamination with Clostridium perfringens. So severe wound pain should be treated with surgical debridement and antibiotics. Febrile non-hemolytic transfusion reactions like fever, chills, or malaise 1 to 6 hours after surgery without hemolysis. Management should be the following: stop transfusion to rule out hemolytic transfusion reaction and give antipyretics to decrease fever, and avoid aspirin in the patients with thrombocytopenic purpura or any thrombocytopenic events. Acute fever, so postoperative day 1 to 3, also day 3, day 5. And after, we have to discuss postoperative day 10 or week 1 to 4, which is subacute, and delayed postoperative day more than 4 weeks. So acute fever, pyretic response on a postoperative day 1 to 3, pyretic response to surgery, which occurs during the first 48 hours. And diagnostic testing is usually not indicated unless there are associated symptoms. After this time period, a complete blood count, so we starting to investigate patient more detailed. So CBC or complete blood count, chest radiograph, urinalysis with culture, blood cultures, and wound cultures are required at first test in all patients. On postoperative day 3, unresolved atelectasis resulting in pneumonia, so patient should have respiratory symptoms like dyspnea at least. Chest X-ray with infiltrates or consolidations, sputum culture, empiric antibiotics administration and modification according to culture results and sensitivity to special antibiotic. Development of urinary tract infections, so do urine analysis and culture. Treat with empiric antibiotics and modify according to the culture results and sensitivity. So detecting and treat, treat. What you suspect, there you get a culture or investigation. Postoperative day 5, thrombophlebitis are very common and may be asymptomatic or symptomatic, and it should be diagnosed with Doppler ultrasound of deep leg and pelvic veins and treat with heparin at that moment. As you know, deep vein thrombosis, around 50 to 70% location is at the pelvic vein, not lower. Acute fever as well, postoperative day 7, pulmonary embolism should be suspected with next signs like tachycardia, tachypnea, pleuritic chest pain. EKG can help us with right heart strain pattern. A low central venous pressure goes against diagnosis to know. Arterial blood gas with hypoxemia and hypocapnia. Confirm the diagnosis with CT angiogram and treat with heparin if recurrent pulmonary embolism. While anticoagulated, the patient should be monitored of coagulation system and especially therapeutic INR or international normalized ratio. If all of this do not help, it's a last call for installation or replacement of inferior vena cava filter. Postoperative day 7 or from 5 to 10, wound infection should be suspected, and risk increases if the patient is immunocompromised, have abdominal and duration of surgery greater than 2 hours, or contamination during surgery. Signs include erythema, worms, tenderness, and discharge local site. Rule out abscess by physical exam plus ultrasound if needed. If an abscess is present, drainage is the first one that should be done, drainage and antibiotics. Subacute fever, so postoperative day starting from weeks 1 to 4, or postoperative day 10. Deep infection, pelvic or abdominal abscess. It is passing infection from one side to another, to which locate or relocate, and if abdominal abscess could be subhepatic or subphrenic. A digital rectal exam to rule out the pelvic abscess, and CT scan to localize precisely local intra-abdominal abscess. Treatment, of course, is drainage. Abscess treatment is drainage, antibiotics. Diagnosis of exclusion includes rash and peripheral eosinophilia. Very important. And delayed fever, postoperative day more than 4 weeks. So subacute week 1 to 4. Postoperative day more than 4 weeks, delayed fever. Skin and soft tissue infections and viral infections. So the above differential diagnosis is for causes that are categorized based on timing. However, there are many other causes that may have specific signs on physical exam and occur after a specific surgery and are not included in the above differentiation. Thank you very much, and see you on the part 2 of this presentation.